Well, we check for MRD, or minimal residual disease, after treatment with a finite regimen, such as either a chemoimmunotherapy regimen, any regimen that has a defined course of treatment cycles. It also could be used to maybe define whether you can shorten up on the treatment cycles. For example, there's not one size that fits all. In other words, if you have a patient who has chemoimmunotherapy, we say one of the best predictors of a favorable response is how well they respond to the first 1 or 2 cycles of treatment. Generally speaking, it's a saying that good patients do well. And so if you have a very dramatic response within the first couple of cycles, that's a good thing because it indicates your trajectory to clearing the cells in the marrow is actually pretty high. And that's different than if you take maybe 5 or 6 cycles and you're still not clearing the cells. So all those patients who achieve a very good response to the first few cycles of therapy, we can say, well, gee, when is enough enough? If we get to a point where we can't find any leukemic cells in the blood and we can't find it by exam, then testing for minimal residual disease at that point might be very useful. Looking at the marrow, very sensitive site, and finding no cells there may allow you to say, gee, I have had 3 cycles of therapy, maybe I have had enough, and not go with 6 cycles of therapy, maybe allowing you to stop therapy sooner than if you didn't have testing for MRD. That makes a lot of sense for me. Now, with the newer therapies that are going on and on and on, with ibrutinib, it's very seldom, in fact, almost never do you find patients clearing all the leukemic cells with a BTK inhibitor, ibrutinib or acalabrutinib, by themselves. However, we're seeing patients clear minimal residual disease with the drug venetoclax. And this is quite astounding because this drug can be taken for a prolonged period, but we're finding that patients, after several months of therapy, some of these patients may have a complete response. And if we look, looking into the bone marrow, we don't see any leukemic cells with very sensitive tests. This is quite exciting because it then could be allowed, just like we mentioned earlier for chemoimmunotherapy, provide us with a means to say enough is enough. Maybe we could stop therapy at this point and be able to go on for a period of time or longer before we require therapy again, and therefore define the course of treatment. Some of our newer protocols are trying to double up on that because if you recognize when we look for minimal residual disease, we're not looking at all the cells in the body. And a good analogy, let's say you had a drawer full of socks and you had maybe 1,000 white socks, and in there you had 1 red sock. And you reached there with a fistful and you pull it out, all you saw was white socks. Well, your test cannot be more sensitive than the number of socks that you have in your fist. And so if you went and reached for all the socks, you'd find that 1 red sock. So to maximize our chance for not missing disease, we're looking at strategies where we look for minimal residual disease in patients treated, say, with a venetoclax-based regimen. And if we don't find it, then we may continue therapy for a few more months just to kind of seal the deal. And then we look again. If we don't find it again, then chances are we kind of come to a very good response, and patients may then, at that point, opt to stop therapy. And we're looking at whether patients who stop therapy versus continue therapy, whether there's difference in outcome. I think that patients who have achieved that level of response may actually do quite well without requiring continuous therapy, and that could be very useful for them.